From the beginning of this course, HCL-420, I have decided to go after topics which may be a little bit conflicting in one way or another to me, whether it be different forms of HIPAA, informed consent, advanced directives, patient autonomy, as well as patient's right to refuse treatment. Each one of those consists of something that I have come to realize may be either in direct conflict with my ethical views, or I have done improperly from time to time. What I have gained through this course, though, is a different perspective, a way to look at things in a manner which, even though contrary to what I may have initially thought, has helped turn and base my decisions upon what is right from not only administration standpoint, but from a patient's perspective. And that is what my final paper is about. It's entitled A Matter of Perspective, and it deals on all those different subjects. The challenges and the conquests in which I feel that I have gained from this course. Initially, I thought HIPAA and its violations. Even though we're all affected by it, we have all come to deal with the legal ramifications and made sure that we are consistent with what the legal aspects of that is all about. Recently, which is not mentioned in my paper, I came across an issue regarding emails and patient information. Now, our physicians that I work with, as well as my manager, instructed me when emailing another physician outside of our department but is involved within the treatment of it, we were to put the patient's name and information in regards to their treatment. Now that we've come this far into this course, I have realized that this was inappropriate, that we cannot put these patient identifiers within an outside email, especially if it was not encrypted. I brought this to my manager's attention, as well as to the physician, my medical director, and they told me to disregard what I felt was inappropriate and to continue doing as such. Even though I argued the counterpoint, they tried to overrule me. I did not let this stop me because it was bothering my conscience that I was doing inappropriately. So I contacted legal department and asked them. They said that I was right, that what I was doing was not correct, and that my job was in jeopardy if I was caught doing so. So I brought this to my immediate superiors' attention, and they said, oh, they were sorry that they put me in this situation, and that from now on no more patient identifiers were to be included within these emails. I addressed the physicians on the outside, telling them our new policy, and they were agreeable with initials, since initials are not identifiers. So this course helped me realize that. Another issue that this course helped me realize was in regards to informed consent. I feel that in the paper that I wrote, I told the doctors that, or the doctors tell the patient on their initial day of consultation, they give them the side effects and the risk and so forth, but it can be a week later before I take a consent form, and it is usually in a generic form. I usually say, this is your name, this is the treatment you're having done to this area, you already know the risk and the side effects, and you're willing to undergo the treatment. If you are willing to do so, please sign your name. That to me is now an inappropriate informed consent. Now I'm going to insist upon the fact that consents are signed at the day of treatment. Our form is no longer going to be generic, but patient specific, stating within that the patient's name, the area of treatment, the risks and benefits that go along with that treatment, as well as what we hope to obtain from the treatment. Some patients think that we are trying to cure them, which in fact it is for palliative care only. This can cause a breach of trust if the patient later finds out that this was not what we intended in the first place. So moving forward, these will be new forms that will be obtained, and I will insist upon the consent being signed on the day of consultation and reviewed with the patient again on the day that they come in for their treatment. The next thing that could come along is, I think, that I've had challenges with in the past, maybe advance directives. Now, I understand that patients have a legal right to either appoint a surrogate or have in place what they want in regards to life-sustaining treatment. Sometimes the issue that I've had in the past with this is that patients don't want any heroic measure. Well, putting myself in their shoes, I'm never going to be really able to quite understand what they're going through until I'm placed in that same position. Myself, I wouldn't want to be put on any life-sustaining treatment if I'm in a vegetative state. I do not want that burden for myself or my family. I wish for them to go ahead and discontinue those instances. But I know what that challenge can be if this is not stated to them beforehand, and they are left to make that decision on their own. I know that they would do what they think was best for me and would not want me to be gone. So they would make me continue to have life-sustaining treatment, which would be contrary. I've listed in my paper the evidence and so forth in order to uphold, as well as, I think, which contrasts the reason for it also. My next issue that I have concern with would be with patient autonomy. Now, I know that patient autonomy, patients have the right to make decisions for themselves. And from time to time, I see that patients don't use their own consideration, but what their family members do. Well, that is not patient autonomy. That is believing in what your family is telling you to do and not what you actually want. So I think that needs to be addressed, and sometimes I need to speak up when I think that a patient is being coerced by family members, and that they need to have their feelings heard and not their family's notions of intent. The last thing, and the most important one to me, is a patient's right to refuse treatment. Now, I know that in regards to this statement, that I've had an issue in the past with why and how can anybody refuse life-saving treatment if it's afforded to them, if they know it's going to advance their lives. Now, it also goes in return with refusing treatment that may prolong their life, and even if they're in pain. Now, once again, I've never been in this situation, and I hope I never am, but I don't think that I could ever be in a position, or let's say I hope I'm never in a position to where I am in such immense pain and suffering that I no longer want to live. Now, my issue with that is, how is it reviewed? Is it willingly taking my own life? Is it considered suicide? My beliefs and morals won't allow me to end my life in a manner that is not consistent with my death from natural causes. So this is where I have to formulate a moral belief that, maybe it is correct in some sort of way, or maybe it's not. I guess we'll never know. And I hope I'm never in that position. Now, everything that I've garnered from this course, I feel that has helped me to formulate a new understanding and a different perspective to looking at things. And I hope that it will be able to form me to be an administrator and a leader in the future that is able to make the right judgment call according to the laws as well as my own conscience. Thank you, and once again, I appreciate everything you've done for me.